we find that guidelines now can at times be written based on the setting or based on the organizations that are writing the guidelines, and maybe kind of some of the focus of the individuals that are writing the guidelines. That focus may, for one guideline, be on one particular aspect of endoscopy processing, but another group of people may focus on something different or disagree. So when you said discourse, it's not even just a discourse, but it's disagreement.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On this episode of First Case, we speak with Dr. Larry Muscarella, principal of LFM Healthcare Solutions, LLC, an independent safety improvement company, and the co-host of the Transmission Control podcast and Transmission Control News Flash with me. So, Melanie, I'm excited to talk to Larry today. I've had him on some of the other podcasts in our family, and he is an absolute expert when it comes to the design of medical devices and also superbug outbreaks, which prior to the pandemic was one of the top conversations in infection prevention, which is the theme for this season.
Exactly. And it made so much sense, I thought, to pull in Larry from Transmission Control when we were doing a whole season on infection prevention and talk to another expert, somebody who knows this stuff, who really can shed some light on these intricate details, on these databases, on the design of our devices, things that we just don't think about or maybe haven't really been taught before, but he's the expert and he can really help us understand how we can prevent infection.
Yeah, and we're going to learn all about the MAUDE Database today, if you aren't already familiar with it. So stay with us till the very end. We're going to be right back after a short break with Dr. Larry Muscarella.
I'm Melanie Perry.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to First Case.
We are speaking with Dr. Larry Muscarella, principal of LFM Healthcare Solutions, LLC, an independent safety improvement company, and he's my co-host on the Transmission Control podcast and the Transmission Control News Flash, which you'll find highlighting Larry's work, and you'll find that on LinkedIn, the YouTube channel for Transmission Control as well. But Larry, I'm excited to introduce you to the First Case audience. Many times throughout this season, we either have or will be referencing something called the MAUDE Database and MAUDE reports. And this is really the focus of your work. And I can tell the audience from firsthand experience that through your work, you've identified concerns and actually relayed them to me. And we've recorded videos long before we've seen anything come from device manufacturers or the FDA themselves on the topic. And so you're very much ahead of the curve, which is why it's exciting to have you on the show. You've got decades of experience in this area. You're a noted subject matter expert. You've been published so many times around the work that you've done. People have probably heard the term superbugs. And so I'll link those two and put it into the context of our infection control prevention season, but looking at medical device design and studying the impact of superbug outbreaks related to flexible endoscopy. And so, Larry, welcome to the First Case podcast.
Yeah, it's exciting to give a little spin in our conversations today. What we've talked about almost exclusively in the medical device field and in flexible endoscopy in general and gastrointestinal endoscopy in particular, I want to try to shift our conversation a little bit into the operating room so that the perioperative nurses can really appreciate kind of some of the stuff that we're talking about and touching on, and how we really want to underscore the importance of some things that maybe aren't getting the attention that they warrant today in the world of cost containment. And that is really adverse events, which is what the MAUDE, or the Manufacturing User Facility Device Experience, MAUDE, that's the FDA's database that houses adverse events. And these are reports that are filed within 30 days, primarily by manufacturers. And I focus almost exclusively on infections, but also some other related harms. So there's a lot going on with that we can talk about. And one thing I just want to, as I say, underscore is that when the listeners are hearing this, really appreciate how important this is and how we can shift back toward focusing on these, because we've talked about this before, Justin, as being safety signals that we can identify in the FDA's adverse events database. This is how the FDA, for example, earlier this year, issued a warning letter to a manufacturer saying we found these two adverse events based on reviews of the MAUDE database. And with regard to urological endoscopes, FDA has come out with safety alerts. And with regard to bronchoscopes and duodenoscopes, FDA has come out with safety alerts. And what is the basis for those safety alerts? Reports they identified in the FDA's MAUDE database indicating a safety signal that something was amiss, that something wasn't right. So this is what's really important about the MAUDE database. Yes, some of the reports can be incomplete. They are not necessarily validated and can contain some inaccurate information. But these are the basis for the FDA acting. And so it's really important that we talk about it today and we bring it into kind of the world of the operating room setting.
So with that, you mentioned that most of these reports that are going are reports from the manufacturers themselves, but MAUDE is inclusive of the user experience. It's actually in the acronym. Can you talk about why we see less reports from users and how that impacts maybe the impact or the validity, or even just, what MAUDE can be for the industry in terms of those signaling even more proactively?
Right. So that's a good question. So every now and then I will read a report where a patient, for example, underwent bronchoscopy or an ENT, ear, nose, and throat procedure, maybe even colonoscopy. And they'll be very emotional and they'll say, I'm sure that I got infected with this bug during that procedure. So those reports from patients are very, very helpful and very insightful. But I like some of the more detached reports where I know they're based more on evidence than necessarily emotion. One of the reasons why it primarily manufactures is because of regulation. So if a device is associated with a death, for example, well, then the hospital may report it to the FDA. But in general, if it's an injury, the hospital reports it to the manufacturer, and then it's the manufacturer who reports it to the FDA. So much because of regulation, this is why the manufacturers are providing it. And the report will state what the hospital or the healthcare facility encountered, and then the manufacturer will give what is called a manufacturer narrative. And then they'll say, we don't know what the root cause is. We're still investigating it. But one thing they often say in the report, this is really important to the world of endoscopy and to the world of infections and estimating true infection risk. And we need to know the infection risk, because if it's high, then we prompt change. If the FDA assesses it as being low, well, then maybe their efforts and their time is spent somewhere else. So we have cases where when you read, I was just reading the July 2023 MAUDE database, and I'm seeing a lot of cases of lapses discussed, breaches. The report may talk about contamination of a colonoscope. It may talk about bacteria identified on a bronchoscope. But routinely, the report will say that no patient harm or injury was identified. And I'm kind of curious, this is something I've never seen or never heard anyone talk about, is why the FDA kind of allows that statement to be there. I think the manufacturer has the right to offer it, but I think maybe the FDA might look at that and say, well, if we're not doing post-procedure surveillance of the patient, where maybe an infection doesn't occur till 2 or 3 days later, how do we know if we're not surveilling the patients, talking to them, calling them, determining whether they have fever or not, and surveillance, post-endoscopic surveillance for infections is not routine, how would we know there were no infections in that real-time assessment? We say we had this breach, okay, there's no harm. I don't know how we know there's no harm. And what ends up happening then is that signal is quieted. And we don't want signals to be quieted. We want them to have, using an engineering term, the appropriate amplitude that it warrants. So that's something that is really, really important, where, for example, bronchoscopes, let's say the FDA may say, well, they're a concern, we've written safety alerts about them, but they don't pose as much of a risk as duodenoscopes, which are used in upper GI tract. Well, I don't know how we necessarily know that because, again, we're not interviewing patients or doing outpatient facilities. They have an exam and they leave the same day. We're not interviewing them or testing them for bacteria. So how would we know whether they are not colonized or infected, subclinically or clinically? So this is an ongoing issue that I think the FDA would do the public a very good service by assuming that the infection rate is higher than the medical literature and the MAUDE database suggest, so that they almost artificially elevate that amplitude a little bit, because I think it's warranted and I think it's in our best interest, and we need a correction factor because we are not counting and capturing all the infections. And so we are presenting concerns about flexible endoscopy, which may also be used in the operating room, where we may, for example, use a duodenoscope percutaneously through a trocar. And so we may have many more infections than we know. And I think we just keep talking about it, but I think it's important that the reports not necessarily, when warranted, certainly do so, but otherwise not necessarily say no patient was infected. Let's say that when we know that, but with infections that can take a couple days to present themselves, let's just be careful about what we say.
So are infections that patients do have, then if a patient does come back later and they do have an infection, are those added to these reports, or is there any way to connect those infections back to the information?
Typically, they don't. The report will say, we'll be supplementing with additional information. You bring up a good point. I'll answer it this way and say that the way these are usually tracked as an infection is when a facility identifies 2 or more people with the same strain, or the microbiology software says, oops, there's a signal here, we could have a problem. We have 2 patients or more that are testing with this rare organism we never see. This then presents itself as being a bona fide infection and outbreak. But otherwise, if the dots are not connected in facility as an outbreak, certainly patients who go home and outpatient, there have been outbreaks that can be linked, but it's much tougher. The patient may go to the primary and just call and get antibiotics for the infection, never going back to the original facility where, for example, colonoscopy was performed, or never going back to the hospital where maybe bronchoscopy was performed. So it's much tougher to connect those dots unless we're talking about an outbreak in a NICU, or an outbreak in a particular operating room setting, or an outbreak in an ICU. Then it's easy to connect these dots, but otherwise it is more challenging to do so.
Larry, what are some examples? Like, let's drill this down a little bit related to some devices and maybe something that you've identified over the last year that really should be maybe called out. And I just want to make sure that the audience can really anchor on some of the theoretical here with some practical, like, this is something you may have read about.
Right. So let's talk about gastroscopes. Gastroscopes are a device used in the upper GI, to examine the esophagus and the stomach. They are now being linked to multi-drug resistant organisms. That's really our concern. You may say 20 years ago, why were we not talking about duodenoscopes? Why were we not talking about colonoscopes and bronchoscopes? We had been talking about viral transmission with colonoscopes in the past, but it's the world of these bacteria now that are dismantling the antibiotics and rendering them inert that we're kind of getting into this whole new world. And I think with gastroscopes, you find report after report, again, just in the last 6 months, you'll see dozens of reports, if not more, of colonoscopes and gastroscopes having clogged air-water channels, or their nozzle is clogged or obstructed with quote-unquote foreign material. We could have dozens of patients that were exposed to that specific instrument with that particular foreign material. And this introduces this possibility of patient-to-patient transmission, then the report will often say no patient infections. Again, I'm going to ask the question without necessarily knowing the answer. How do we know there was no patient harm? We didn't get all those patients together. Now, if those patients are all testing positive and showing symptoms of disease and infection, and they're all being cultured and sampled and have the same organism, well, now we know we have a problem. But the gastroscopes, there are infections, but I think they're underreported in the FDA's database. And I think the FDA would serve a really good function in public health to alert the public that it's not just duodenoscopes, but it's also bronchoscopes, urological endoscopes, and gastroscopes that it can expose patients to multi-drug resistant organisms. So a real key aspect of this is not just me talking about adverse event reports. It's the FDA following on the heels of what I'm saying, concurring and saying, you're right. He's pointing out these safety signals. We need to alert the public, because that's the kind of the tipping point, is when the FDA says to the operating room, there's a problem. If a researcher says there's a problem, there will be some who will heed advice and will make changes, but it's really the CDC and the FDA that are crucial to tying the loose ends and moving this forward. And I think they need to continue to do what they're doing, but do it, for example, with gastroscopes and echo endoscopes might be another example, ultrasound endoscope. These are posing risks and they're just being underreported. And we need that FDA's help kind of to publicize these concerns.
How can people working on the front lines help in that effort? If there's one researcher or only two researchers that are looking at a particular topic, isn't it hard for it to sort of bubble to the surface and impact change or get that on the FDA and the CDC's radar to address in maybe a brighter light? Yeah,
that's a really good point. And we would encourage, certainly in every single safety alert that I've read or several that I've read recently, the FDA does say in the safety alert to the public, if you're aware of any adverse event, please do report them. Easier said than done. For example, resources, availability, takes time. And if nurses are focusing on patient care in general, and even COVID patients in particular, as they had been in the past, superbugs really became, something that was kind of in the background. I think they're starting to reappear. We did see reports recently this spring about a number of patient deaths in a hospital out west, Klebsiella infections. They cannot identify the source, but just recently, within the last couple of weeks, I think there was a 7th patient who died. There's multiple patient deaths, more than 30 infected. Take, for example, 5 years ago, this would have been reported in the newspapers every single day until the problem was solved. Today, it's kind of one of those things where, well, if you look for it, you'll see it. But it's almost as if Klebsiella infections that are associated with mortality aren't as important as they were 5 years ago. And I'm kind of questioning why that's the case. And I don't exactly know, but I think it could go to the point of staff being very limited. When they identify a problem, if they can go to risk management in the hospital and then have the hospital report these cases so that those signals start popping up in the FDA's database, I can tell you FDA will act. But if those reports are just kind of seen as the cost of business, they're not reported, even though federal regulation require any type of serious injury, such as an infection linked to a reusable medical device or any type of medical device. This is something that regulations require be reported. But I think there's kind of been a shift to some degree because of limited resources and the aftermath of COVID, that some things that were very important and even as important today are being pushed to the back burner. And I'm hoping that we can continue to move them to the front burner, but doing so is challenging and easier said than done.
So you mentioned something in scopes just a second ago that was blocked when we were using it on multiple patients. What was that again?
Right. So generally in a gastrointestinal endoscope, there's a feature where you use air and water. And the water, for example, comes through a nozzle at the distal tip. And that allows the physician to cleanse the lens at the distal tip so that if foreign materials on that lens, they activate a button called the air-water valve that causes water to become ejected from the distal end. And there's a nozzle, a metal flap, that then directs that water over the lens. So we cleanse the lens for visibility. Well, that particular nozzle, that particular air-water channel that then is affronted by this nozzle at the distal tip, there's report after report after report of it being occluded, foreign material being found in it and clogging the associated air-water system. And this is with patient debris and therefore poses a risk of cross-infection. We're not seeing the reports of the cross-infection, and that is likely due to two possible causes, if not more. The first one is in the colon, when you're exposed to someone else's foreign debris, maybe the epidemiology is such as that you don't get infected. With viruses, you tend to, but maybe with bacteria, you don't. And the other possibility is that these many reports this year alone and years in the past of that air water nozzle at the distal tip being jammed, clogged, backed up with patient debris, patient mucus, for example, that maybe those are being linked to infections, but the infections aren't being captured because the patient goes home. I think an FDA alert pointing out specifically that there is a safety signal that could be a risk, that facilities need to make sure that in their cleaning and disinfection of the flexible endoscope, of the GI endoscope in particular, that those models that have this air-water channel and this nozzle, that extra attention be done to scrub them because of the plethora of reports talking about them not being cleaned. That to me is a no-brainer. FDA would put out a safety alert. It would be an education alert simply saying there's a possibility of this transmitting multi-drug resistant organisms. Please check and make sure that the nozzle is being cleaned. Maybe FDA would say that's for the manufacturer to do in some type of a corrective action, where the corrective action might be putting extra emphasis in the operator's manual. So I'm not sure whether I would say it's the FDA's responsibility to do it or the manufacturer's, but it's a safety signal I'm observed that I think needs more attention than it's currently receiving.
All right. So my brain is turning because the facility that I work in, our operating room staff also staffs endoscopy. And so I take my turn in endoscopy at least once a month to go do colonoscopies and endoscopies and whatnot. And so we have all of these scopes. And until I had actually started working with Beyond Clean and First Case, my understanding of all of these scopes was incredibly limited. And I'm still just amazed at what these scopes can do. But now that you're talking about all of this, I'm really curious. What should we be doing to make sure that our scopes are clean, that we don't have stuff occluding channels and things so that we could possibly expose our patients to things?
So that will go directly to management. We need trained personnel, reprocessing staff. We need to ensure that they're competent and that they periodically review the manufacturer's instructions for use, that they're familiar with each different colonoscope model and type, and that they assure that each potentially contaminated channel or surface is being addressed. So it's not just looking at one generic colonoscope or one generic duodenoscope or just one generic flexible endoscope, if you will. They have different number of channels depending on the model. One might have an ultrasound transducer, the other doesn't. So it may have a balloon channel, which is something that we use where water passes through to fill a balloon on the distal end to allow for enhanced ultrasound imaging between the endoscope and the mucosa. These all have channels, so we need to audit staff. That's probably the most important thing. Now, it's going to go back again to time. It's going to go back again to resources. And another interesting quirk, there's an argument that's unconscious in all of our minds, if not at times conscious, that if you don't look and find a problem, well, then you can sleep at night because there's no problem. So you're getting into a can of worms if you start investigating and looking under the sheets to see what's really there. But that I'm encouraging that we do that. If we find a breach, we then go to our corrective actions, our root cause analysis, and we solve the problems. I'm not suggesting any of this is simple. I'm not suggesting that management wants to identify all problems because this opens Pandora's box in some facilities if there are outbreaks going on that they're unaware of. So there's kind of, if you don't look, you're kind of safe. I'm encouraging to look. The patients want us to look. But this is something that is, in summary, again, make sure your staff are trained. Make sure they're being periodically audited to make sure that their practices are complying with the procedures and policies of the facility, and that those policies and procedures need, of course, to be consistent with the manufacturer's IFUs or instructions for use. So this is it's a quality assurance measure is really the answer to your question.
Definitely.
So, Larry, Melanie just asked the question around what should we be doing related to the guidelines in our facilities. But I also know that there's been a lot of public discourse around industry guidelines and that they don't always line up. And there's definitely been some efforts to get some synchronicity there so that you don't have, maybe one outpatient setting following one set of guidelines in a health system, and then the inpatient setting is following a different set of guidelines. And honestly, there's research going on all around the world as well. So it's not just US based guidelines. Can you give us just kind of a lay of the land on guidelines at that higher level?
Right. So that's a great question. And we find that guidelines now can at times be written based on the setting or based on the organizations that are writing the guidelines, and maybe kind of some of the focus of the individuals that are writing the guidelines. That focus may, for one guideline, be on one particular aspect of endoscopy processing, but another group of people may focus on something different or disagree. So when you said discourse, it's not even just the discourse, but it's disagreement. So let's talk, for example, in the U.S., there's been a movement toward the sterilization of flexible endoscopes, particularly certain flexible endoscopes like bronchoscopes and duodenoscopes. And so in the U.S., they've been promoting sterilization. The CDC has always recommended sterilization of semi-critical instruments, such as flexible endoscopes, such as duodenoscopes, such as bronchoscopes, but that when not feasible, you would high-level disinfect. Some guidelines recently have kind of eliminated that caveat about feasibility and simply say these are high-risk devices. They have to be sterile when they're used. I'll come back to that in a second, but say that a guideline recently came out of Australia that underscores high-level disinfection of the gastrointestinal endoscope. So we're talking about high-level disinfection in one country or one setting. We're talking about sterilization in another. I think two important points to sterilization of flexible endoscopes. Is it ideal? Absolutely. Is it something I recommend? Absolutely. But there's a little bit of a quirk that I don't hear discussed at all, and I'll just bring it up here very briefly because the operating room community may really appreciate this. When we're talking about a scalpel, for example, or a cardiac catheter, we need a sterile device that we introduce into sterile tissue, and that when it is touching the organs inside the body, for example, the heart or the submucosa, if it's a scalpel, we're talking about sterile instruments contacting sterile tissue. Therefore, the instruments need to be sterile. It's what a critical instrument is. But what if we have a semi-critical instrument like a flexible endoscope that we say, well, it has to be sterile. When it contacts the lungs, it has to be sterile. There's something that argument has overlooked. And that is that, for example, the bronchoscope. We can have a sterile bronchoscope. It's been sterilized, maybe ethylene oxide gas sterilized, maybe it's even packaged sterile from the manufacturer. The moment that it enters the mouth, or the moment that the cystoscope enters the urethra, or the moment that the colonoscope enters the colon, it is now contaminated. So by the time it reaches its objective, let's look at the bronchoscope, the end of the bronchoscope is already contaminated with oral flora. So when it's in the lungs, it isn't sterile. It can't be sterile. Yes, it's generally the patient's own endogenous bacteria, but that's not what sterile's definition is. An instrument that is only contaminated with the patient's endogenous bacteria, sterile means that it's not contaminated with exogenous. No, sterile means it's not contaminated and it's devoid of endogenous or exogenous. So that's the first point, is the flexible endoscope, because it's used, unless it's percutaneous, will always be contaminated and therefore arguably can never be anything more than a semi-critical instrument, but for which we recommend sterilization when feasible. And the second issue that comes up is when we say we need to sterilize flexible endoscopes, how? I'll ask it as a question and not give the answer because I don't know the answer. If we want duodenoscopes to be sterilized, or we want colonoscopes to be sterilized, or gastroscopes to be sterilized, how is that happening? What hospitals have the sterilizing technology on hand in order to achieve that end? So the move to sterilization of flexible endoscopes is a much bigger issue than just a group of people getting together and saying, I think there's a high risk they have to be sterilized. It's much more complicated than that. And this is very important in the operating room setting. Now, if we take a sterile instrument, it's been, for example, a bronchoscope, it's been exposed to a low temperature sterilization process that the facility has, and it enters maybe through an incision in the chest. This is all great. This is sterile, contacting sterile tissue. But when we're going through an orifice in the body, the argument of sterility starts to break down.
So what are some alternatives to this? Because that's super interesting. And there's the whole debate, like you said, sterilization versus high-level disinfection. But typically when, an industry is challenged with a debate, or a difference of opinion this way, there also comes innovation. And people want to solve the problem by having new technology sort of address it at its roots. One of the things that I've noticed in a lot of your research is new technology also presents additional challenges in that the technology itself hasn't necessarily had a broad application. And so very much in the purpose of the MAUDE, as new technologies emerge, we need to gather that data because it's also what drives continued innovation on that new technology to be even more effective. What are some new methodologies or technologies that have arisen, as this high-level disinfection versus sterilization debate continues?
Two directions I'll go on that. The first one is directly answer your question, is the technology of high-level disinfection versus sterilization. You can have single-use sterile flexible endoscopes, for example, that get you away from the whole problem of having to reuse the device and then sterilize it using a technology in central supply, where maybe the sterilizers, the low-temperature sterilizers you have in central supply haven't been validated for that particular flexible endoscope, in which case that creates a whole number of problems. But I think in that sense, the single-use sterilized and then delivered to the hospital, wrapped and sealed, and then used sterile kind of is a way of getting around this problem. Again, still, once it enters the mouth, if it's a bronchoscope, it's contaminated with endogenous bacteria, and therefore it is not sterile at the time that it contacts the lungs, which are the sterile tissue. So we're not able to get around that problem, but the single-use disposable devices do get us around the problem of patient-to-patient disease transmission, whether it's a virus, whether it's a prion, or whether it's a multi-drug resistant organism. So that is an advancement. There are some issues that go along with that, cost per procedure, for example, but as time is going on, this is all starting to move in the direction where probably, certainly in some scenarios, that single use is going to be applicable. And I have two thoughts now. The second that I was going to talk about was the advancing technology, where we have this duodenoscope, for example, and it had a fixed end cap, the operating room people may know. And then the FDA said, let's transition to distal end of the duodenoscope where we have a removable distal end, a removable end cap to facilitate.
So like a hybrid technology.
Exactly. It will be a single-use, generally sterile end cap that will be put on for each procedure on a reusable duodenoscope. It's interesting kind of Peter and Paul analogy here, because something that goes to the point that's very important, design validation, is that when we now designed a distal end that could be removed after each procedure, thrown out, and a new distal end cap put on the endoscope, again, we came up with this end cap design that was disposable so that it could be removed, and then we could brush and get better access at the distal end. It has worked. The number of outbreaks and infections linked to the conventional duodenoscope with a fixed end cap, that number was significantly higher than the number we're counting now with this hybrid where this distal end can be removed. That FDA recently came out with a letter to a manufacturer where they started saying we're seeing two new safety signals. What were they? They're that end cap falling off inside the patient, inside the GI tract, inside the airways. And these can have problems with respiratory distress, or it can have problems with leaving this end cap in the patient's GI tract. And that's the number one adverse event associated with these hybrid is that the problem of the end cap becoming detached, falling off in the patient. And then when it does, there's some sharp edges on the end of the endoscope that are then reports are indicating they can cause mucosal and tissue injuries with and without bleeding. And sometimes when we lose that end cap, now we have to do x-rays. We may have to do a CAT scan. We've got to find where that end cap is. So we kind of move from Peter to Paul, where yes, we've reduced the risk of the adverse event of cross-infection, but now we've introduced two previously unfamiliar adverse events of mucosal injuries and detachment of an end cap inside a patient's, for example, airways, which has some obvious complications that can go along with it.
It can never just be easy, can it?
No, it isn't. And when we talk about design validation, when we come up with a hybrid, we want to do the necessary verification tests to make sure that the end caps don't fall off and that there will be times where they do fall off. For example, when withdrawing the duodenoscope, if that distal end hits the bite block, it might cause that end cap to then become dislodged and get caught in the patient's throat. But then we can come up with mitigations that say, okay, let's have a warning. Let's have instructions in the IFUs that say when removing that duodenoscope, be very careful. Remove it carefully and slowly and keep an eye on the distal end so we don't dislodge it. So the point is every new design has its problems. Let's just hope that those problems are less than the original design that we were correcting. And it looks like, I guess, all things said, we don't have the same high number of deaths and multi-drug resistant outbreaks associated with the duodenoscopes, but now we have some problems with mucosal tears. But I think as we continue to move on, we're going to find ways to better attach those distal ends, those single-use disposable distal ends that facilitate access and cleaning. We're going to come up with ways of making sure they attach better. And therefore, it's kind of a quality improvement situation where we're going to get to where we need to be, but we're not quite there yet.
Larry, this has been a really engaging and insightful conversation. I don't know that everybody out there really has a good grasp on, how medical devices come to market, things like 510K approval. It certainly would be a great conversation to tail off of this one at some point in the future as well. It's like, how does the magic happen behind the scenes in the industry and what are the guardrails? And, but one thing that I really appreciate about the conversation is you seem to keep a healthy balance between where the opportunities for improvement are and where the practicality lies as well, because we can't make wholesale changes every time we see something. We also can't stop performing life-saving procedures when, it's a smaller percentage of risk versus what the risk is to just not performing the procedure altogether, right? And I think sometimes, people, and you talk to any layman out there who's a patient with no healthcare experience, they're all going to tell you that their assumption is that the instruments that are used on them during a procedure are all single use. The whole concept of reprocessing surgical instruments is not something that I think the general public understands.
Right. And I'd like to stress this, particularly in the operating room setting. The operating room in the United States is kind of the gold standard where we as patients, we as the public look to it as this pristine, clean, sterile, confidential place that we go and someone takes care of us. And I think it's a wonderful, priceless situation. The operating room is really at the top of the pyramid. But I want to discuss or focus or just comment a little bit on the culture and how we can work toward getting back to where we were so that we can start focusing again more and more on the patient. And I know there's limited resources. I know the hospitals have a lot of financial stress, but I think each individual operating room nurse can contribute to fixing this problem. That is taking us where the reports of the infections where they might not have been reported or maybe they kind of were viewed as something that's not all that important. I think we need to get back to focusing on the adverse events in general, the infections in particular, get them reported, talk about them, get out there and report to risk management, report to each other's colleagues, present at conferences so that we can get back to realizing that adverse events and infections are important. There was kind of a hiatus with COVID, but we need to get back to the superbugs now. They are hurting patients and we need to refocus on them. And the operating room staff, who are as committed as anyone, are the best people to take that baton and to get us across the finish line.
Excellent interview, Larry, and great closing advice, something practical after a lot of insight that maybe the audience is like, what am I supposed to do with this anyway? In the end, well, how do I put it into practice? Right. And I think you did a great job of wrapping that up for the audience, that this is something that you can do now that you have this information. That was Dr. Larry Muscarella, principal of LFM Healthcare Solutions and my co-host on the Transmission Control podcast and Transmission Control News Flash. And Melanie, I know you've had a chance to interact with Larry in the past before this podcast, but obviously not nearly as much as I have. And when it comes to superbugs, outbreaks, and medical device design, I don't know of anybody who has more experience and understanding of how the design of these medical devices can impact or maybe complicate infection prevention practices in our facilities, and specifically the operating room. I'm sure lots of things that maybe our audience weren't aware of related to superbugs and healthcare-acquired infections.
No, you're absolutely right. I've talked to Larry a few times, but being able to just benefit from his knowledge and how much he knows about the design of this equipment, and then to learn about the MAUDE database, because I've never heard of that. And so finding out what that does, what it encompasses, and how it can help us is just really almost mind-blowing to know that it's out there and that we can use that to just create awareness.
Yeah, I think one of the things that we can do so much at this podcast is increase the awareness of resources like that. I mean, especially if you're involved in any kind of value analysis process, to be able to look up new products that you're evaluating in that MAUDE database and becoming aware of maybe other end user complications. And sometimes it's just a lack of education. It's not even a design issue, but just knowing ahead of time where maybe other hospitals have reported some struggles, I think is a really great way to make use of that tool. So on behalf of Melanie and myself, thank you for listening to this week's episode of First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.